So good morning. So we'll go ahead and get started. First, I want to thank the hardy group of people you are who made it here today for this really, which I know will be an interesting and important talk. But thanks for everyone for kind of taking the morning shift and getting here. So it's my pleasure to introduce Dr. David Fiellin. Is that right? Fiellin. So we've been discussing how to pronounce his name after 20 years, but and he says, any way you say it, Stephanie, is fine. So there we go. Anyway, from now on, I'm going to call him David in the rest of my introduction. So David is a professor of medicine, emergency medicine, and public health at Yale University. He directs the newly formed program in addiction medicine, as well as the community research and implementation core at Yale's Center for Interdisciplinary Research on AIDS. He is a primary care general internist who's also board certified in addiction medicine. And I'm proud to say that he was a fellow in our clinician scholar training program under the leadership of Dr. Bruce Rounsaville. So we always take a lot of credit for him in our renewals every 5 years. So it's great to have him as an alumni of that program. His work focuses on the interface between substance use and general medical settings. And in this area, he has really emerged as a leader, particularly in relationship to the treatment of opioid addiction. Specifically, as one example of this, he directed the buprenorphine training efforts for the American Society of Addiction Medicine for 5 years and was the first medical director of the Center for Substance Abuse Treatment's physicians clinical support system for buprenorphine. He's also, as you might imagine, the recipient of numerous awards, including the Neiswander Dole Award, the annual award from the American Society of Addiction Medicine, the Spickard Excellence in Mentorship Award from AMERSA, and the Dan Anderson Research Award from the Hazelden Betty Ford Foundation. He's been very instrumental in policy initiatives, and some of these are reflected by his appointment to the White House Office of National Drug Control Policy, Drug Control Research, Data and Evaluation Advisory Committee, and the World Health Organization and the United Nations Office on Drugs and Crime Technical Guideline Development Group for psychosocially assisted pharmacological treatment of opioid dependence. I think you will consider his talk today very timely. As we all know, the United States is in the midst of a deadly opioid epidemic that's affecting all parts of our country, including Connecticut. His efforts to expand access to treatment are an essential component of our local and national response to this problem. I hope that his talk today will inspire you to be part of the solution through your research, teaching, and clinical service. So with this, I would like you to help me welcome him to the podium.
Thank you very much, Stephanie. I appreciate that very generous introduction, and I appreciate the opportunity to be here and talk through issues as they relate to what is currently a major public health crisis in the United States. I have no disclosures and no conflicts of interest. As far as an outline for today's talk, I'm going to talk a bit about and fairly briefly about the scope of the problem. I think if you're paying attention and following the news, to any degree these days, you're inundated with facts that used to be difficult to actually determine what was going on, and number of people with opiate use disorder, number of people receiving treatment. Now all I have to do is open the Wall Street Journal or the New York Times or CNN, and the data is right there. So it certainly grabbed the attention. I'll talk about the importance of expanding treatment, and in particular the work that the Yale DSA and many of the mentors that I've had over the years have helped as far as expanding access to treatment through research over the last 20 years. And then sort of address the central question of my talk today is, are we there yet? Have we reached the tipping point where we're now addressing opiate use disorder or addiction in general medical settings to an adequate degree? And then I'll talk about some work that we've been doing with the state over the last year, as a number of states have been trying to pull together responses to the opioid epidemic and the unique opportunities that has provided, and then leave you with some, unfortunately, somewhat disparaging thoughts about potential and future international threats as they relate to opioids. So I just want to contextualize the sort of current opioid epidemic that we're experiencing in sort of a historical framework. In the 1800s, there was problems with morphine prescribing and morphine distribution, and what at the time was characterized as a morphine epidemic. And all of these epidemics are sort of laid upon each other. In the 60s and the 70s, we had the heroin epidemic that was primarily focused in urban settings, laid the groundwork for much of the HIV transmission and Hep C transmission at the time. But certainly it has been sort of the undercurrent that we've been dealing with for probably 50 years or so, and was part of the genesis of much of the work to expand access to treatment that was taking place even before the quote-unquote current opioid epidemic. This was all fueled by the provision and primarily diversion of prescription opioids, increased prescription of opioids despite lack of evidence of efficacy for a large proportion of patients for the treatment of chronic, in particular chronic non-cancer pain. And you'll see some of those numbers with respect to the increase in the prescribing. And that has led, because of the diversion, patients who are unable to get access to these, or more commonly, individuals who had been able to access these through diverted means, transition to the less expensive heroin. And now what we're seeing on top of that is very high potency opioids that are being distributed by many of the cartels that were in existence because of the heroin distribution networks, with very high potency fentanyl that is very closely associated with much of the opioid mortality that we're seeing of late. But I think it's important to recognize that this epidemic didn't really start in the late 90s or 2000, that we've had a series of epidemics, and this is laid on top that has really complicated the problem in many parts of the country. So what is the scope of the problem? And it can be very difficult to decide which metric is the most salient and the most important to focus on. And I've listed a number of metrics here that we could think about. What are the numbers of those with opioid use, both licit and illicit? What are the numbers of those with opiate use disorder? What are the number of individuals that are impacted? The spouses, the partners, the parents, the children, the friends, the coworker. This is a number that is difficult to quantify, but really needs to be recognized. There's a lot of focus on the overdose deaths and not as much focus on those who are living with non-medical use or opioid use disorder and the impact that that's having on their families and such. The financial implications, the infectious implications, problems related to increased prevalence of neonatal abstinence syndrome around the country, and then what's getting a lot of the headlines are the overdose deaths. So just to give you quickly some numbers, 92 million individuals prescribed opioids in 2016, 11.5 million with quote-unquote non-medical use based on diversion of these medications, estimated to be about 3 million individuals with opioid use disorder in the country. 2 million of those are primarily due to prescription opioids. This impact on spouses and others, individuals, is really unknown and difficult to quantify, but needs to be remembered as we're addressing this. Financial implications, the Council of Economic Advisors indicated that it's estimated that it's at least $504 billion per year. Infectious complications, we're seeing increases in HIV transmission, increases in endocarditis, increase in hepatitis C transmission. There's the famous case of Scott County, Indiana, very rural setting where there were 160 cases of HIV infection based on transmission of dirty needles between partners who are using Opana. Increase in neonatal abstinence syndrome, estimated that it's about 5.7 per 1,000 live births, and increased from 1.2 in 2000. And in 2012, nearly 22,000 individuals or neonates with neonatal abstinence syndrome. Overdose deaths estimated in 2015, 33,000 are specifically opioid-related. The preliminary numbers for 2016 are 42,000, I believe. So clearly a situation that's out of control and impacting a large segment of society. This sort of tracks the overdose deaths per month by the CDC between 2000 and 2016. You can see a rise in prescription opioid deaths, heroin opioid deaths, and then the new player is obviously the fentanyl that's being distributed both as fentanyl and as heroin that's driving much of the opioid deaths of late. So this slide sort of provides the background for why we're interested in expanding access to treatment outside of standard treatment settings. So the gray counties on this map are those counties that have at least one opioid treatment program. And the green or brown or yellow are the ones, or orange, are the ones that have no such treatment programs. And you can see, especially in areas that are heavily impacted, Appalachia, Northeast, wide swaths of the country do not have access to evidence-based treatment, the most effective treatment, or specialty treatment settings. And so while it's reasonable to posit that we should just expand opioid treatment programs, there are numerous federal regulations that prohibit the opportunity to do so, at least in a rapid fashion. And so the idea is that we need to think of other options that can be used to help expand access to treatment for those individuals who need that. And again, I want to thank my mentors and colleagues at DSA, in particular Bruce Rounsaville and Richard Schottenfeld, but also Kathy Carroll, Ismini, my mentor Patrick O'Connor, Tom Costin, and Stephanie, for really 20 to 30 years ago thinking about expanding access to treatment for substance use disorders through the network of primary care practices. There were starting to be effective medications and psychosocial treatments that could be expanded to the areas where I work. And it was really sort of that forethought that led to the line of research that I'll be discussing. In fact, in 2000, Tom Costin and Bruce Rounsaville wrote a very nice editorial in JAMA that focused exactly on this. And this was in the setting of rapidly expanding heroin and lack of access to treatment. And Tom and Bruce commented that implementation of primary care treatment for substance use disorders offers the possibility of increased access to care for these common and untreated disorders. Careful study will be required to maintain and improve the quality of that treatment. And I took this as a marching order in 2000 to really sort of determine and decide the type of research that I was going to do, focusing not only on access, but also on the quality of treatment. But again, this is almost 20 years ago, and folks here were already attuned to the fact that we needed to think about expanding access. So why primary care and why general health settings in particular? I guess I would start with the Willie Sutton quote, which is, "That's where the patients are." So this is where the majority of health care is delivered for both medical and psychiatric comorbidities. It's already an established national health care infrastructure. It's not like we have to address things that relate to regulations or build new buildings. These settings already exist. They're seeing the patients. It's also potentially associated with less stigma. So when I treat patients in the primary care center for opioid use disorder, they're sitting in the waiting room with patients who have asthma, diabetes, congestive heart failure, and nobody really knows why they're there. And they appreciate that opportunity. And in fact, it provides the opportunity for them to have fewer interactions, potentially with patients who are early in treatment and may not be doing as well. And in addition, this is all in the setting of longitudinal patient-provider relationships that we in primary care typically have with our patients. And it provides the opportunity for integrating the care of their medical comorbidities along with their substance use comorbidities and sort of providing a one-stop shopping. So I think this was the reason that Bruce and Richard were really thinking about the opportunity to expand access through primary care settings. Our first work was funded by CSAT and was a pilot demonstration project in the state of Connecticut to take patients who had been stabilized on methadone for at least a year and transfer their care, randomize them to either transfer their care to an office-based primary care physician or to have them stay in the opiate treatment program. And after 6 months, we were able to demonstrate that patients were equally likely to be retained in treatment if they received their care in the primary care setting, and similarly that there was no difference in illicit opioid use, again, if they were receiving their care in primary care compared to staying in the opioid treatment program. This was back in 2000. People thought we were crazy to try to bring patients with opioid use disorder into a primary care setting. There was concerns among the practitioners that their VCRs would be stolen or that there'd be issues, that tells you how long ago it was, or that there'd be issues with disruption. And again, I just want to acknowledge all of the work of Patrick Merrick, Mike Pantalone, and Richard in helping us put this forth and really sort of demonstrating that these patients could continue to potentially do as well in primary care settings as they could in an opioid treatment program. This was all around the same time that the federal government was working to try to expand access and to try to more normalize or mainstream the treatment of opioid use disorder based on the emerging evidence that supported the efficacy of medications such as buprenorphine. And so it literally took an act of Congress to allow physicians to provide an opioid to treat a patient with an opioid use disorder long term. Because of the problems in the morphine epidemic in the late 1800s and 1900s, the Harrison Narcotic Act in 1914 specifically prohibited providers from providing opioids for the treatment of opioid use disorder. So the Drug Addiction Treatment Act of 2000 allowed qualifying physicians at that time, it's now been expanded to include both nurse practitioners and physicians associates, to use FDA-approved Schedule 3 to 5 medications for the treatment of opioid use disorder. This was followed in 2002 by the FDA approving buprenorphine and the DEA moving it from Schedule 4 to Schedule 3. So buprenorphine and buprenorphine naloxone were now available for the treatment of opioid use disorder. And so it made less sense to think about taking patients who had been stabilized in methadone and moving them into primary care settings rather than thinking about taking patients directly into treatment in primary care and office-based settings. And this legislation and these regulatory acts allowed us to do that. So just as a brief piece of background, buprenorphine is a partial agonist at the mu opioid receptor. It has efficacy that's similar, perhaps a little less efficacious than methadone for the treatment of opioid use disorder. It's cross-tolerant at the opioid receptor. It provides a level of blockade. And really one of the two medications with the strongest literature base with respect to their efficacy in decreasing overdose, decreasing HIV transmission, decreasing drug use, decreasing criminal activity, a wide swath of evidence to support the efficacy of these medications. The advantage of buprenorphine is it can be prescribed by physicians and dispensed at prescribed by clinicians and dispensed at pharmacies. So no longer did patients, in order to receive treatment, have to go to one of these federally regulated opioid treatment programs, of which there are only 1,000 in the country, and get their treatment on a daily basis for the first 90 days and then start to get their medication dispensed. They could now receive treatment the way they potentially receive treatment for other types of medical conditions. So the legislation required that clinicians have the ability to refer patients for psychosocial treatment, but it didn't prescribe what that type of psychosocial treatment looked like, how long, what the dose of that treatment was supposed to be. And there was some literature in the methadone world based on work by Tom McClellan in sort of the mid to late 90s that demonstrated providing increased level of psychosocial services was associated with increased retention and decreased illicit drug use. And so, again, I want to give recognition to Richard Schottenfeld and the idea that it was important now that this medication was going to be disseminated throughout the healthcare infrastructure and throughout primary care to look at what would be the appropriate or optimal level of psychosocial counseling for patients receiving buprenorphine in settings such as primary care. And so we conducted a study. We enrolled 166 patients. These were patients who were seeking treatment primarily at an opioid treatment program, but agreed to participate in research that was based in primary care. It was a 24-week clinical trial. All patients received buprenorphine naloxone, and they also received physician management, which was 15 minutes a week or 20 minutes a week for the first 3 weeks, and then spread out to 15 to 20 minutes a week for every other week after, based on level of stability. But in addition to that, or on top of that, they got 3 levels of psychosocial counseling and 2 different medication dispensing regimens. So the first arm received standard nurse-administered counseling that was sort of a mixture of motivational enhancement therapy and psychoeducation. They had their medication dispensed on a weekly basis for take-home. The other 2 groups had their medication dispensed for take-home, but the medication was dispensed on a thrice weekly basis, and they either received 20 minutes of similar counseling or 45 minutes of enhanced counseling, which included worksheets and really sort of a deeper assessment and treatment related to their psychosocial issues. Patients, again, 166 of them, although few had current untreated substance use disorders, they had a fairly high prevalence. About a third of them had a lifetime prevalence of alcohol use disorder or cocaine use disorder, a small prevalence, 4% with sedative, primarily benzodiazepine, and psychiatric comorbidity, about 43% of them had a lifetime history of depression. And this was the primary finding with respect to self-report of illicit opioid use that we saw. I think the first most startling thing is this is weeks of treatment. This is self-report of opioid use per day. And you can see that with all 3 treatment strategies, just with initiating treatment, we saw profound decreases in opioid use from the start. And I have to say, when I talk to primary care physicians, I let them know that this is actually one of the most rewarding types of treatment that I provide in a primary care setting. It's rare that we see such precipitous declines in symptoms and disease status so quickly. And so, patients kind of come in after the first week and saying, "Doc, you're great. This is the best medication. You're the best doctor in the world." And it's very reinforcing. I think the other main finding, obviously, that you can see is that we're unable to distinguish a difference in outcomes between the 3 treatment arms in this research. And similarly, when we looked at treatment retention, there was essentially, an unfortunate drop-off, and so only about 50% of patients were retained at 6 months. But there was no, again, we're unable to detect a difference in the 3 treatment groups with respect to treatment retention. So I think this was an important finding. It didn't, confirm what we thought a priori would happen. And then we decided to repeat this work, not using nurses as counselor, but now using psychologists and master's level trained psychologists and doctoral level psychologists, and provided cognitive behavioral therapy versus medication management. And again, we're unable to detect a difference between those 2 treatment arms. We looked at this in HIV positive populations, and there was a NIDA Clinical Trials Network trial looking at this in patients who have prescription opioid use disorder who are receiving buprenorphine. And again, they were unable to detect a difference between those patients who received standard medication management versus enhanced psychosocial services. This has been looked at by others. Walter Ling at UCLA did a similar trial, compared medication management to all patients receiving buprenorphine, medication management to patients who receive motivational enhancement therapy, and patients who receive cognitive behavioral therapy, and was, again, unable to detect a difference across those groups. A Cochrane collaboration meta-analysis looked at both buprenorphine and methadone and compared trials using varying levels of psychosocial services, and concluded as well that they were unable to distinguish a difference, and indicated that most patients, as long as they were receiving not only medication but some level of medication management, did as well as patients who were receiving extensive psychosocial services. And Kathy Carroll and Roger Weiss have written about this, done their own review of the literature, and concluded that there is a certain spectrum of patient population that can do well with a lower level of psychosocial services, and that perhaps it might make sense to think about a stepped care approach as opposed to an obligate high level of psychosocial services for everybody from the start. So I think as we're addressing this epidemic and the number of deaths and number of lives impacted, and we think about expanding treatment access, I think it's very important that we think through the spectrum of opioid use disorder. And I'm not just thinking about DSM-5 and mild, moderate, severe, but even among patients who have severe opioid use disorder, their sort of underlying clinical status, their level of motivation, their psychiatric comorbidity, and not assume necessarily, at least from the policy perspective, that from the get-go all patients need aggressive psychosocial treatment and wraparound services, that there's certainly a lot of patients who can benefit from a lower level of medication management as long as it's in the hands of providers who are providing high-quality treatment. And it's the idea of not letting the perfect be the enemy of the good when we're facing sort of a national crisis, and recognizing that, at least a third to a half of patients may do very well with a lower level of services as provided through primary care or other types of settings. So now that we have the ability to provide this type of medication and we have demonstrated efficacy, the big question becomes, will physicians do it, right? I work in addiction medicine, and I'm fond of saying it's often harder to get providers to change their behavior than to get my patients to change their behavior. And so, this is a new aspect of medicine that most folks have not been exposed to. And I want to tell a brief story, an anecdote about a physician in St. Charles, Virginia. This is Art Van Zee. He's a family physician in that area. He's been working there for probably 50 years or so. And back in 2000, this is where he is. It's sort of right the western corner of Virginia, near the Kentucky and Tennessee border. It's sort of a triangle there. Back in 2000, Richard Schottenfeld received a phone call or an email from Dr. Van Zee saying that he was taking care and burying kids from overdose, teenagers, that he had birthed. 19, 20-year-olds. And Dr. Van Zee was feeling as if he was in the heart of an emerging epidemic and felt like this was patient zero from the HIV era. And Art was reaching out and trying to get some help and support. And so Richard and I had the opportunity to go and talk with him at the time, meet with the local community, and hear stories of a father who would get up, worked in a bank. He would get up at 4 o'clock in the morning every morning, drive his son to Lexington, Kentucky, 2 hours away, so his son could get a dose of methadone, and then drive back 2 hours so that he could be at work 8 o'clock in the morning. And he had done this for 6 months for his son, just so he wouldn't relapse. And all we could say at the time was, we think buprenorphine is in the offing. This was 2000, but we need to help you with a rich level of psychosocial services and other types of treatment. Art was really impacted by the work that the pharmaceutical reps were doing in this area. This is all outlined in a book that I'd recommend to you, written around 2002, called Painkiller by New York Times reporter Barry Meyer. And just one quote from the book says that by November of 2000, the tone of the Van Zee emails to Purdue Pharma also conveyed a mounting sense of urgency. And this is quoting Art. Also important, I think that Purdue, and this is an email to Purdue, I think that Purdue stop aggressive marketing of OxyContin. It has proved to be a medical, social, legal, and societal catastrophe. And this was the battle that Dr. Van Zee was fighting in 2000 against a large corporation and the aggressive marketing of medication that was leading to a heroin epidemic, an OxyContin epidemic in rural Appalachia. And he's written about this in the American Journal of Public Health, but he's sort of one of the unsung heroes who sort of sounded the sentinel alarm early on. Art subsequently adopted buprenorphine for treatment and has had a large amount of success, and is really sort of emblematic of a lot of primary care physicians in Maine, in Wyoming, rural areas, and even in urban settings that have taken to their community's needs and provided this type of treatment because of the public health impact that they were seeing was taking place. So Declan Barry and I and a group did some qualitative work asking primary care physicians whether or not they would provide this type of treatment. And that work sort of is reflected in various quotes that they provided. They said the most satisfying part to me is that to get all of their treatment under our physician's control and managing patients in one clinic setting. But there's also the lack of training and support that they feel. And they say, I guess because it's something we're not really taught about at all. It's not like it comes up in your pathophysiology class or comes up in your third-year rotation. I've done nothing in addiction medicine through medical school or residency or other training. So this was the feeling in 2000. It's still the feeling in various communities around the country today, although I will say that medical schools and residencies are starting to address this to a greater degree. And then this is a quote from somebody who clearly hadn't read our research. He said, we don't really have the capacity and support here to do everything else that goes along with it. We have inadequate social services in the clinic itself in terms of social work, drug and substance abuse counseling, psychiatric mental health counseling. It's inadequate. And I would just leave with the notion that it's not, it's very common for us to care for patients in primary care for their diabetes, for their hypertension, for their coronary artery disease, and they have very large needs with respect to psychosocial and psychiatric comorbidity. So it's not as if this is anything in particular that's unusual for this patient population. Because of this, we worked to create a network to support prescribers who were starting to prescribe buprenorphine around the country. As Stephanie alluded to, I directed the buprenorphine training efforts for ASAM for 5 years, and it felt like drive-by technology transfer. We'd show up in Oklahoma City, we'd do an 8-hour training, we'd leave, and leave no infrastructure. And so what we did was we created a virtual infrastructure of mentors who were high-quality individuals doing medication and doing treatment right. They were skilled in teaching, and we basically tried to match those individuals with people who were receiving training and were starting to provide this type of care. So this map sort of outlines in red the opiate treatment programs in the country. In green are our mentor contacts, and in blue, sort of the registered participants that we were providing support for. So by email, by telephone, by on-site visit, you could match up with a colleague who had been there and could show you how to incorporate this type of treatment. And that's really grown to now the PCSS medication-assisted treatment, PCSS-MAT, that Ellie McCants-Katz and others have helped to distribute and provide support around the country on a range of addiction-related issues. So we moved from primary care to HIV clinics. We did a series of research that was funded by HRSA. Yale combined with the New York Academy of Medicine to be the evaluation and support system for 10 clinics around, 10 demonstration sites, HIV clinics around the country who were interested in incorporating buprenorphine. Richard, myself, and others provided backup and support. And all of these settings had a 1-year follow-up for their patients. We ultimately enrolled 344 HIV positive participants, and of those, 303 received buprenorphine, and a smaller number were referred to off-site to methadone. This is all written up, if you're interested, in a supplement to the March 2001 Journal of AIDS Research, or JAIDS. And we looked at a variety of outcomes, including quality of treatment, quality of HIV care, HIV outcomes, substance use outcomes, and in particular focused on retention and demonstrated that at some level there was no difference in retention in those who were receiving care in an opioid treatment program compared to those who were receiving those receiving treatment in the HIV clinic compared to those receiving care in opioid treatment programs. We did a randomized clinical trial with the group at Hopkins where we randomized patients to either receive their buprenorphine within the HIV clinic or sort of the standard referral to the opioid treatment program, which is really only about 2 blocks away. And you can see as far as the percent engaged in treatment, those who received office-based buprenorphine were 80% engaged at 2 months compared to 35% randomized to methadone, and that persisted through the entire 12 months of the trial. Similarly, when you looked at illicit opioid use, the patients who received care within the HIV clinic less likely to have opioid-positive urines than those patients who received care off-site receiving methadone. So demonstrating, again, to the extent possible when you can provide and integrate services within clinical care settings, typically the outcomes are better. So based on this work, we decided to move into emergency departments, and this is all based on the leadership of the chairman of the Department of Emergency Medicine here, Gail D'Onofrio, who is willing and a ready passenger in trying to expand treatment access through emergency departments. We published a trial about 2.5 years ago now in JAMA that was emergency department initiated buprenorphine versus 2 other treatment strategies. We are essentially interested in comparing the efficacy of 3 interventions for DSM for opioid-dependent patients in the emergency department. Interestingly, this was an RFA that was designed to evaluate brief intervention and referral to treatment. I'm not a huge fan of brief intervention and referral to treatment, so I said, okay, how about if we actually provide treatment or initiate treatment in the ED the same way we do if somebody comes in with hypertension or asthma or diabetes. But we essentially gave we had 3 different treatment arms. These were patients that were screened for opioid use disorder. They either received the sort of standard referral to treatment. Here's a list of treatment in the community. I hope you make it. Brief intervention and facilitated referral. So this was a much more robust, brief negotiated interview provided by a research associate, and really sort of tried to match their referral to the patient's desires and their insurance status. And then the third group also got the brief intervention, but in addition, they had their medication initiated in the emergency department. They got a dose of buprenorphine if they were in withdrawal. If they weren't, they had the opportunity to start the medication at home, and then they had a follow-up in the primary care center within 72 hours. We enrolled 329 patients between 2009 and 2013. Just highlighting the level of complexity of this patient population. We essentially had very little in the way of exclusion criteria. This was all comers. 10% of the population came in with overdose at the index emergency department visit. 23% required psychiatric clearance in the emergency department at Yale New Haven. 88% had any psychiatric symptoms according to the ASI in the past 30 days. And the main outcome was that those individuals who received treatment in the emergency department for their opioid use disorder at 30 days were nearly twice as likely to be engaged in some form of addiction treatment compared to those patients who received just a referral or a referral plus a brief intervention. And in fact, I think this is probably better than you will see in many other urban settings and many other emergency departments that don't have the same robust availability of treatment services and a place like App Foundation that basically takes people on demand. But nonetheless, certainly demonstrating that by initiating treatment in the emergency department, you'll certainly be more likely to have patients engaged at 30 days. Their illicit opioid use was less at 30 days. And they used fewer inpatient treatment services, and that was borne out, and fewer healthcare services, and that was borne out in a cost-effectiveness evaluation that Susan Bush conducted, essentially demonstrating that with respect to willingness to pay, the initiation of buprenorphine was dominant over all other treatment arms. So now I get to the point where I talk about how do we get people to do what we know works, right? So I like this slide. It leads into the discussion of implementation science. It says the latest research shows that we should really do something with all of this research, especially in the face of an epidemic. And implementation science, while my early studies were efficacy and effectiveness, here the impact is really how can you change a health treatment system? How can you take efficacious treatments and move them into settings so that people will use them with good fidelity? And I know that both Kim Yonkers and Steve Martino in this department are aggressively working on these types of issues. We were able to convince the NIDA and the Clinical Trials Network that we had adequate evidence to support ED-initiated buprenorphine. We didn't need to repeat the trial from an efficacy or effectiveness standpoint. What we needed to do was to start to get emergency departments to implement this and focus on the extent that they're able to do so. So we're currently running an implementation science trial. Gail and I are the lead investigators. This is all through the New England node where Roger and Kathy are the PIs. And it's essentially a type 3 hybrid effectiveness multi-site stepped wedge design. I'll give you a sense of what I mean by that shortly. And we're focusing primarily on implementation, whether or not EDs start to provide this type of care, and with also an effectiveness outcome, whether or not patients do better if they've been exposed to this type of care. So the overall trial, we take each site and we evaluate for a 1-year period of time. We look for the prevalence of untreated opioid use disorder. We see what happens with patients who are treated during the evaluation period. And then we do a focused implementation where we help each of the emergency departments implement this type of care and work with their networks and referral centers around in their community. And then we evaluate to see whether or not that implementation had the desired impact. So we're going to be working, we're actually currently working with Johns Hopkins in Baltimore, Mount Sinai in New York City, University of Cincinnati, and Harborview in Seattle. And so hopefully within the next 2 to 3 years, we'll have results from that. Again, the idea is, can we impact the treatment system and increase the proportion of patients that receive what seems to be an effective type of treatment? So, are we there yet? So I'm ambivalent about this, right? And you'll see why. So back in 2000, there were probably about 250,000 individuals who were receiving methadone for the treatment of opioid use disorder, and that was it with respect to the availability of opioid agonist treatment. So in 2016, there were about 350,000 individuals, and an estimated about 600,000 individuals who are receiving buprenorphine. So at some level, we've doubled the capacity of the U.S. healthcare system to provide the most effective treatment for patients. And this is all borne out if you look at buprenorphine treatment visits from 2003 to 2013. You can see that they're clearly increasing over time. The proportion of those patients that are receiving care from primary care, general medicine, family medicine has vastly increased to the point now where the majority are receiving that care in general medical settings. So in 2003, 92% of prescriptions were written by psychiatrists, whereas in 2013, it was about a third coming from psychiatry, about a third from internal medicine, about 15% from family practice, and the osteopaths got all lumped together, but that was about 14%. So clearly more patients receiving this type of care in general medical settings than perhaps in specialty treatment programs or through psychiatrists around the country. But demand has outstripped the availability of treatment. This slide shows changes in methadone over 2003 to 2012, very little in the way of change. Increases in buprenorphine prescribing over that time, and then the proportion of patients who are receiving any kind of opioid agonist treatment, either methadone or buprenorphine. And you can see we still have, similar to 2000, a large treatment gap where it's estimated that only 20% of those individuals who need treatment have access to treatment. And that has led us to the current situation where we have opioid use disorder and overdose driving much in the way of attention and policy these days. This has not escaped, obviously, federal agencies or state agencies, and we had the opportunity to work with the state of Connecticut to come up with a strategic plan to address the issue of opioid overdose and opioid addiction in the state. This was similar to a call from the National Governors Association in July of 2016, where they provided a blueprint for states to work through how to implement such strategies in their states. A number of states have responded, Maryland, South Carolina, Massachusetts, Illinois, with strategic plans designed to strategically address issues in their state. Our initiative use collaboration from a variety of individuals, myself, folks in public health, folks in psychiatry, folks in internal medicine, folks in emergency medicine, and then we worked with the folks who had developed the strategic initiative in Rhode Island, and Josh Sharfstein, who's at the Bloomberg School of Public Health at Hopkins, and has worked in the policy realm before. Over a 3-month period of time, because this is an epidemic, we wanted to come up with a rapid process and a rapid response. We consulted with local and national experts. We met with over 50 stakeholder groups around the state. This included non-governmental groups, state agencies, elected officials, city agencies, federal agencies. We reviewed the local data from the state, and I'll show you some of that. And then we developed what we thought was a succinct, prioritized 3-year strategy that should guide efforts. It's basically fairly straightforward, 6 strategies, and then 20 tactics and methods that could be used to track the progress that we're making in this area. We took public comments on a draft report and then revised and submitted this to the governor. So I just want to give you a snapshot of what Connecticut looks like with respect to the opioid epidemic. And I'll just pause here and just how devastating it is for the state. 888 individuals in 2016 were fatal opioid-related deaths in the state. This is increasing over time, and just a public health catastrophe for us, not unlike many other states. And I really view each of these individuals as either untreated, undertreated, or perhaps overtreated, right? So if they're being prescribed opioids and at a way that would adversely impact their health. And so there's a huge opportunity for us to try to disseminate appropriate treatment for all of these individuals. Demographics, mean age of 42, 74% male, 83% white, 25% with evidence of injection at the index event. 81% of these events are happening in a house or apartment, so it supports the rapid availability and expansion of naloxone. A smattering of opioids involved. Prescription opioids alone was only 24%. Fentanyl, this is 2015, 9%. It now looks like it's going to be involved in probably 50 to 60% of the deaths in 2016 and 2017. Benzodiazepines, and this is the next epidemic, right? 42% of these individuals had benzodiazepines in their system at the time of death. And I'll show you some data about benzodiazepine prescribing in the state. Only less than half had any evidence of contact with the prescription drug monitoring in the state. So just a reminder that patients have ready supply of access to opioids that doesn't involve what we can see in the prescription monitoring program. Skip Barber, Rob Heimer, and Loretta Grau did some great graphing and mapping work showing the reds are opioid-related deaths, the blue are opioid treatment programs, and the yellow are buprenorphine providers in the state. And you can see that there are areas that are being impacted where we just don't have appropriate access to treatment. And so it's a microcosm of the rest of the country with respect to that. Similarly, naloxone availability through prescribing pharmacies are the blue dots, deaths are the red dots. A lot of areas of the state where we don't have adequate access to naloxone around the state. The opioid treatment programs in the state have really met the call. They've ramped up access to treatment to the extent that they can. They increased from about 14,000 in 2011 to about 17 or 18,000 in 2015. This number has plateaued a little bit, but that's a nearly 30% increase in expansion of methadone in the state. Buprenorphine, however, has remained stable at between 19 and 20,000 patients around the state on an annual basis. This slide sort of depicts where we are with prescribing of controlled substances in the state. The most commonly prescribed controlled substances in the state are benzodiazepines. This really highlights the extent to which they're potentially contributing to the overdose deaths that we're seeing, and certainly diversion of these medications is important. The other thing that we were interested in doing was to seeing what proportion of prescribers were providing the opioids that are prescribed for the treatment of pain. It would be great to try to train and address the quality of opioid prescribing of the 25,000 DEA registrants in the state of Connecticut, but it turns out that a relatively small number of individuals, are prescribing a large number of the opioids. And so if we can target and focus our quality efforts on those individuals rather than broad strokes across people who may not be prescribing at all, I think we'll get more bang for our buck. So in the last few minutes, I'll just talk through quickly the strategies that we're trying to use to address the situation in the state. We're trying to increase access to treatment consistent with national guidelines with methadone and buprenorphine, strategically expanding opiate treatment programs, promoting same-day treatment into opiate treatment programs. There are only 2 in the state that have the ability to do that. Increase buprenorphine availability in a variety of settings. We're providing trainings to that effect. And increase access to medication throughout the continuum of treatment. So if you go inpatient these days and you have an opioid use disorder and you're on either methadone or buprenorphine, you have to stop that medication in the majority of the situations, and that's not consistent with what we know works best for this disease conditions. This is just a graph that shows you what happened in Baltimore when they expanded access to buprenorphine, to methadone and expanded access to buprenorphine. Their overdose deaths dropped precipitously, and they saw this in France as well in the mid-90s. We want to reduce overdose risk, especially among those who are at highest risk, accelerate opioid overdose survivors' entry into treatment. They should go directly from the emergency department and get engaged in some kind of treatment, rather if they're interested and able to do so. Widespread availability of naloxone, reduce receipt of opioids greater than 90 milligrams morphine equivalents in those patients who are receiving these medications for the treatment of pain. We know that that's a dosage that's associated with increased overdose mortality, and the combination of opioids and benzodiazepines, as I stated earlier, is also associated with increased mortality. Increased adherence to opioid prescribing guidelines, increased access to and the tracking of naloxone, increased data sharing across regular public health agencies, relevant public health agencies. So if a patient comes into emergency department with an overdose, I want to know whether or not that patient was receiving a prescription for an opioid at the time, and I want to know whether or not that patient got engaged in opiate agonist or what type of treatment that patient was engaged in within 30 days. So currently, this is cataloged in one data set, this is cataloged in another data set, and this is cataloged in another data set. And none of these data sets speak to each other. And so we urge the state agencies and the governor to create memorandum of understanding so that we could actually monitor and determine the extent to which patients who come in with a life-threatening condition are either exposed to medication that might have precipitated that and get into some kind of treatment. So we need much more fluid data access across various data systems. And then we just need to work on issues around stigma and understanding of opiate use disorder, understanding of the appropriate type of treatment, and even the basic language that we use, using words like addict or clean or dirty. There's a study by John Kelly out of Harvard where he randomized mental health professionals to receive vignettes about patients, and in one vignette, the patients were referred to substance abuser, and in the other vignette, they were referred to as an individual with a substance use disorder, so person-first language and a diagnosis. And those folks who received the vignette that referred to somebody as a substance abuser were more likely, again, these are mental health professionals, more likely to believe the person was culpable and more likely to report that punitive measures should be taken. So I think the language that we use as we're speaking to the public is very important with respect to this. So the academic and state initiatives that I just described provide us with the opportunity to help them embrace science-based treatments and strategies, focus on the highest risk individuals and the highest risk providers, and hopefully maximize use of local data. So I'm just going to end with what I see as potential future threats. You're probably all aware that the majority of opioids that are prescribed in the world are prescribed in the developed countries and prescribed in particular in North America and the United States. And the World Health Organizations and others are trying to address this by expanding access to opioid analgesics around the world. And that's appropriate, especially for indications such as palliative care. Where we start to get into trouble is the efforts by groups. This is the reincarnation of Purdue Pharma, Mundipharm, and they're now working around the world to try to increase the use of prescription opioids for the treatment of moderate to severe chronic pain. And if that sounds familiar, that's where we were in 1995 and 1996 in the United States. You know, they want this to be a global effort. And some very interesting work by Harriet Ryan in the Los Angeles Times, where she spoke to individuals about their plan. You know, OxyContin is going global, and they say they're only just getting started. This has raised concerns not only by myself, but Keith Humphreys, who's out at Stanford, where he looked at the standard daily doses of prescription opioids across about 30 countries, and you can see the USA is much higher than all other countries in the world. And I think we just need to be very cautious about avoiding replicating the public health catastrophe in the United States internationally. So in conclusion, opioid crisis was long in coming and is far-reaching. Expanding access to treatment includes primary care and other general medical settings. And I'm happy to say that the Yale DSA, the Program in Addiction Medicine, and the School of Public Health have already and are poised to provide leadership both locally, nationally, and internationally. And with that, I'd like to thank and acknowledge my DSA and psychiatry mentors and collaborators. Thank you very much.